Welcome back. I'm Hanish Bansali, one of the PTAC community members. At this time, I'm excited to welcome four amazing experts for our listening session who will share various perspectives on reducing organization-level barriers affecting participation in population-based total cost of care models. You can find their full biographies and slides posted on the ASPE PTAC website. At this time, I ask our presenters to go ahead and turn on your video if you haven't already done so. After all four experts have presented, our committee members will have plenty of time to ask questions. The full biographies of our presenters can be found on the ASPE PTAC website, along with our other materials for today's meeting. So I'll briefly introduce our guests. Presenting first is Dr. Clif Gaus, the past president and chief executive officer of the National Association of ACOs. Welcome, Clif.
Thank you. And I think we're about to begin here, so let me just run through my brief number of slides. I have more slides in the deck than I'm going to use. I'm going to first introduce everybody to NACOS. It is certainly the spokesperson for majority of the ACOs in the country, over 500 members, and serving a 9.5 million 13 million beneficiaries in the ACO program, both CMMI and the MSSP programs. We like to think of ourselves as three-legged: thought leadership, education, and advocacy. And I should point out that NACOS is member-owned and member-governed, and it's a nonprofit association of ACOs. Next slide. So this is kind of my depiction of where we have been over the decade. Certainly, the ACO model has grown from the beginning to now over 13 million traditional Medicare beneficiaries in the models, over 700,000 clinicians, and a pretty good record, though not as significant a savings record as those of us who were in the early years of creating the program thought would occur. But it is probably the only Medicare value model that has consistently shown savings over the last 10, 11 years. And those savings are, like I said, while not what all expected, they are not insignificant, with gross savings of over $28 billion, not counting the 2024 experiences, which are substantial as well. So and 100% of the ACOs have met the quality standards. Next slide. I'm going to talk mainly about benchmarks, but I wanted folks to kind of see my perspective on sort of what the adoption challenges have been, and basically there still is significant misaligned incentives. Sometimes for certain physician groups, remaining in the fee-for-service mode can still be the stronger financial option. It's a huge investment required to transition to value, and even a bigger investment needed to participate in one of the federal programs just because of the overhead. There's burden associated with the quality reporting in those programs. And the last probably impediment is the whole issue of benchmarks, which I'm going to devote most of my remaining few minutes here on. So next slide. The benchmark challenges that have stalled participation include first of all, the goals are to set the budget for treating patient populations and getting that historical spending, the start point right, has been obviously a big challenge. There's also the accounting for the individual patient factors. no ACO, no physician group treats the same kind of patients, and those factors affect the cost tremendously, and therefore trying to adjust for those has really been an important and significant challenge. And then once the benchmarks are set, accounting for the changes in spending patterns are always a challenge. And we have a whole range of methods that adjust for those, but they're not perfect by any means. Next slide. This slide here is it's a portrayal. I'm not going to go through the details of it, but the two major programs in accountable care are MSSP and ACO REACH. And we put in this chart sort of also MA because there's been a lot of discussion of recent about how can there be a more level playing field between the value-based care programs of Medicare, MSSP, and REACH, and MA. And as you know, from more recent literature, but also literature from as long ago as 10 years, the MA program has prospered well. It is the dominant program in Medicare now. And however, it is that program in large part because of the subsidies that are inherent in the MA financial model. I won't go into those in detail, but there is a need over the long term, and maybe we can discuss this in our conversations later, about what some of those changes might be implemented to provide a more level playing field for both patients and providers. Next slide. So in terms of benchmark challenges, the three components of the benchmarking are, one, setting the actual start point, and it's not as simple as everyone would think. Traditionally, it had in almost every program, it is finding out, determining that historical spend for that group of patients for whom the ACO is responsible for. And that also includes, over the long term, and I'll mention this a little bit later, but the ratchet effect, and where that has now become a major impediment for new ACO growth and for continuation of some ACOs in the program. The MSSP program has implemented a variety of adjustments over time in their policies to adjust for changes in spending, regional adjustments, prior saving adjustments, trend factors. And the second, in mentioning trend factors, the prospective trends create certainty, but they also are inaccurate. And no one can predict precisely what our costs are going to be next year, nor for the next 5 years, which the newest of the MSSP models have incorporated a factor in ACPT, accountable care prospective trend, that locks in a trend for new contractees for 5 years. And as we found in our recent analyses, this estimate presumably is significantly off this for 2024, and ACOs are in a position here where they're going to be potentially significantly harmed by just an inaccurate estimate that's getting locked into the 5 years of spending. And then lastly, the risk adjustment component of benchmarking is probably one of the largest differences between MAs and the Medicare accountable care models. ACC scores are used in both programs, but there are caps that are on the accountable care entities. There are caps on rising scores, and those are not the case in MA. And that has been one of the contributing factors to why MA has become such a big growth pattern, and the preferred financial model in Medicare for physicians in participation. So I think that wraps up. In conclusion, I do have one more slide. How do we improve the program? Well, we need to make the benchmarks more predictable and stable. We need to allow for adjustments when the predictions fail, and this is debate we're entering into now. But my colleagues at NACOS have before them a major challenge to communicate with the new administration about how to fix this misalignment that occurred in the estimates for the 2024 reconciliations. And thirdly, to provide the ACOs a more level playing field with MA, also improving the business case in general to grow the beneficiaries in traditional Medicare into the accountable care models. And then lastly, a better way of increasing the inclusion of past savings into new benchmarks to avoid this, I call it the death spiral. It's a ratcheting down of benchmarks as an ACO improves what it does and what it saves. Its benchmark gets harder to meet, and that occurs especially when the contract is renewing. So I'll close here and turn it over to my colleagues.
Thank you so much, Cliff. We're saving all questions from the committee until the end of all presentations. Next, we are excited to welcome Dr. David Johnson, Assistant Professor of Urology at the University of North Carolina and Clinical Operating Partner at Rubicon Founders. Please go ahead, David.
Thank you, Dr. Bensali, and thank you to the PTAC for inviting me to speak. My name is David Johnson, Clinical Operating Partner at Rubicon Founders, practicing urologic oncologist at UNC Chapel Hill. And prior to joining Rubicon Founders was the Medical Director for Value Transformation at Blue Cross in North Carolina. I'll be speaking today about the role of conveners in increasing participation in population-based total cost of care models. And all views are my own and don't represent my current or past employers. Next slide, please. So in the context of population-based total cost of care models, I refer to a convener as an organization or an entity that engages multiple stakeholders to facilitate the implementation and execution of value-based care models. Conveners engage stakeholders differently based on their specific model. But in general, the convener is the risk-bearing contract holder with the payer. Payers can mean anything from commercial plans, MA plans, CMMI, as previously alluded to in the last talk, or at-risk PCP groups as well. So payer can be a broad term in this context. Secondly, the conveners engage or partner with a provider organization. They can partner in terms of care delivery. They can also partner to align financial incentives and work together to deliver on the outcomes of that total cost of care population-based contract. We're going to hear from a couple of sophisticated and in one case integrated healthcare systems coming up here. And so just keeping in mind really what I'm talking about here refers primarily to independent community physician groups that are interested in participating in these total cost of care models. And finally, in terms of patient engagement, it's also variable based on the type of provider group that the convener is working with, the services that the convener is set up to provide, and then also the contract terms. And again, while many of the principles that I'm speaking about today very much apply to the primary care models, my main focus here is actually on how conveners can enable specialists to participate in these types of risk models as well. Next slide. So with that in mind, it's worth noting that specialists like myself, we're trained to deliver reactive, episodic, transactional, face-to-face, and hands-on care. And the systems that we practice in are set up to optimize it and facilitate this type of care. And so Clif introduced some of the barriers in the prior talk. But when we think about just some of the basic requirements that provider organizations need to master, or at least have, to directly assume financial accountability for both medical costs and outcomes for an entire population of patients, it's not surprising that this feels like a pretty steep mountain to climb. And particularly with specialists, it's there's been challenges on adoption because of a lot of these requirements and reasons. So in the next few minutes, I'll discuss how conveners can help play a role in supporting practices to meet these requirements to make participation feasible. Next slide, please. So first, population-based total cost of care model fundamentally requires a sufficiently large population to achieve actuarial stability. We just heard a little bit about all of the challenges of benchmarking on a large primary care population. And when we start thinking about smaller populations and more specific populations, all of those issues are further amplified. And so as we move beyond primary care accountability rather, providers are increasingly taking risk on more narrow populations, sometimes defined by an entire specialty service line like cardiology, or even a set of clinical conditions like in the GI space with inflammatory bowel disease. And so conveners are often required to aggregate risk across multiple practices, geographies, lines of business, and payers, just so even moderately sized physician practices can participate in these models. And again, as Clif discussed in great detail, the actuarial exercise to set these benchmarks is extremely challenging. And your typical specialty practice lacks any actuarial expertise to validate what they're signing up for in these risk models. And so conveners can be helpful in this way by helping identify cost variation, looking at savings opportunities, and helping project forward future expenditures in order to validate the viability of this type of risk models for specific populations and for specific provider groups. Next slide, please. And from a financial standpoint, in order to meaningfully participate in risk, it requires significant cash reserves and financial capital for care transformation investments. So unfortunately, provider groups are not sitting on mountains of cash like insurance companies, so they don't have the financial wherewithal to ride out down years or errors or misses on the benchmark, as we just discussed. So conveners can help by shielding provider groups from this downside risk, as well as maintaining adequate cash reserves to meet statutory requirements for taking two-sided risk in the first place. Additionally, significant upfront investments are required to successfully deliver on population-based outcomes, particularly when being implemented in a traditionally reactive transactional fee-for-service environment. And so conveners are often necessary for that initial outlay and ongoing outlay of capital for investments in things like clinical infrastructure, additional staff, particularly those that don't generate revenue but are high value in a fee-for-service world, and technology, including population health management tools, technology to collect and act on patient-reported outcomes, and performance dashboards for quality reporting. Next slide, please. So another foundational requirement for managing total cost of care of a population is having a complete and real-time view into what's going on with the patient outside of the clinical walls. So as we know, our fragmented healthcare delivery system results in an even more fragmented system of information sharing on patients. And so conveners are often able and required to make investments in real-time aggregation of both clinical and claims data, as well as collecting and identifying other barriers to health, such as social determinants, that are not always top of mind for providers seeing a patient day-to-day in the clinic. And finally, specialty providers that want to successfully manage total cost of care must really make a shift in their clinical focus from a reactive transactional fixing of a problem once it occurs to a more upstream approach of early detection, prevention, and when appropriate, conservative management. And as alluded to previously, specialty care delivery systems are set up to thrive financially through volume and productivity under the traditional fee-for-service incentives. And so providers must be willing to undergo what's really not a trivial clinical mindset shift. Conveners can support this shift by helping integrate innovative high-value care models into clinical practice, which in my experience can only have a transformative impact if they're evidence-based, both patient and provider-centered, and done in close collaboration with frontline clinicians. And importantly, they have to coincide with meaningful, attainable outcomes-based incentives. Next slide, please. So I'll close by calling out the obvious that all conveners are not the same. So it's important when a provider is evaluating partnering with a convener to understand what are the actual services and functions that are offered by this convener. What is the convener's business model? How are they adding value to the practice? How are they making money in their contract? It's also important to understand how these services and functions integrate into the core clinical operations of that provider care delivery system, especially how it's going to impact the patient's experience. It's also very important to make sure that the care delivery vision of that convener is aligned with the partner practice, and that financial incentives are also aligned in the right direction. Finally, payers must consider why a convener is better suited to provide the services or functions than the practice. It's obviously necessary in a lot of ways to bring additional capabilities to these providers, but it is adding another entity, and some call it a third party, into the mix, and so there must be a justification for that. The payer should also look at what is the degree of practice integration and provider buy-in that's required for success. And part of that really relies on how attractive the convener's clinical model and partnership model is for network practices. The payer also must consider whether the convener is willing to take on downside risk, and whether the payer goals actually align with the goals of the convener and the business model. So thank you very much for your attention, and I look forward to the question and answer session. Thank you.
Thank you so much, David. Now we are happy to welcome back our former PTAC co-chair, Dr. Angelo Sinopoli. Thank you, Lee, who is the Executive Vice President of Value-Based Care at Cone Health. It is great to have you here, Angelo.
Thank you. It's great to see all my previous PTAC colleagues. I've missed seeing you all and participating in the discussion, so thanks for inviting me back. As was stated, I'm a pulmonary critical care physician. Spent most of my career as chief clinical officer of large health systems, although I did spend a 2-year stint working in a venture capital backed convener organization. So I have a little bit of experience on both sides of the equation. But to the point, I'm going to be spending most of my time today talking about health systems, their clinical integration efforts, and their barriers to clinical integration. So you can go to the next slide. So kind of starting out with what is clinical integration, and obviously there's different levels of clinical integration. I will point out also that I forgot to mention that Cone Health is now a member of Risant, which is an entity that was developed by Kaiser to support health systems across the country who are interested and have a strong history of value-based care. Cone is the second health system in that structure, the first being Geisinger. And so we are working together, across Kaiser, Geisinger, and Cone Health to develop clinical integration and value-based care products. So when we think about clinical integration, it's more than just a group of docs agreeing on a set of quality measures to measure themselves against. It's really bringing hospitals together, physicians together, care teams together, and to focus on quality, efficiency, outcomes, and affordability. You got to have great physician leadership. I used to call it, you have to have a madman present to really drive that sustainability, and certainly care coordination, data, and aligned financial incentives. Next slide. So this depicts a more of an integrated healthcare delivery system. So if you think about care from the home, and then you think about virtual care, community resources, mobile clinics, retail pharmacies, all the way up to the most expensive hospital admissions, and then post-hospital for rehab, skilled nursing, outpatient, and then back to home. So the real goal for health systems in this arena is to clinically integrate all of those assets to make patient experiences seamless. What that requires is a data and technology system that spans that entire set of assets that drives data and patients across the system seamlessly, so that you're not throwing patients over the wall, as I describe it sometimes. you also have to have a horizontal care management, care coordination, disease management group that's managing those patients across that continuum along with those technologies. Next set. So this is what it would look like in a different depiction here. So again, utilizing EMS, utilizing mobile clinics, all your community resources. And we frequently describe this as having a medical neighborhood approach with our healthcare assets reaching out into the community, and also developing an accountable communities approach where we're working with community-based organizations, county and state agencies, et cetera, to integrate care across all of our geographies. Next slide. So, one of the big things that health systems run into, and as do practices, is that there's a foot in both canoes, fee for service and APMs, and it is very difficult to really transform care until you hit about 40 to 50% of the practices patient panel is under some type of significant value-based care. Also, until you get to that point, you're not really seeing enough value-based care to cover the startup cost of entering those kind of products. There was one estimate in 2016 that the startup cost for this was about $1.8 million, which was much higher than the CMS estimates were when they started these programs. And actually, at the time, one of the Health and Human Services secretaries quoted a Midwestern ACO that the startup cost was actually $30 million. And so it's very hard to think of covering that with a small APM, with a small amount of your practice in APM models. Next slide, please. So, part of the answer to that is to extend beyond just MSSP or REACH programs. You've really got to get to a point in a health system or a practice where the majority of your patients are under some type of risk arrangements. So reaching beyond Medicare to Medicare Advantage, to Medicaid, to commercial payers. Some organizations have their own provider-owned health plan, and direct to employer contracting. As you add those up, then the practices in the health system reach a critical mass such that they have enough patients under that kind of payment model to really be able to transform care. Up until then, the fee-for-service always outweighs the need to manage care and to keep people out of the hospital. Once you reach 50 to 60% of your patients under this kind of arrangement, then all of a sudden an admission does become an expense, and the investment in all those tools and clinical integration becomes justifiable from a finance standpoint. And I always make the case that the uninsured is 100% insured by the health system, since we are responsible for those. Next slide. So again, what enables clinical integration? It is certainly a critical mass of APM patients, the proper governance and physician engagement, the proper financial incentives. Unfortunately, right now, the value-based care payment models emphasizes the financial side of that, but really doesn't pay for clinical integration per se. The technology, care coordination, patient engagement, and contractual and legal mechanisms are all required to create true clinical integration. Next slide. So, so luckily, particularly from a health system standpoint, the more risk that you are taking, so if you're only doing contracts that give you pay for quality, or very low levels of risk, there's a lot of restrictions in what you can do to support your doctors to create alignment and to create that clinical integration. As you move to where you're having significant amounts of downside risk, global risk arrangements, systems where 30 to 40% of their revenues are related to some pre-PMPM, then the 2020 OIG final rules actually allow for a lot of flexibility in what you can do for physicians to help pay for care coordination, to help with their technology needs, et cetera. So next slide. Also with, this is just another slide to outline some of the restrictions that are the OIG covered in that 2020 release. Next slide. And also being able to provide stronger incentives for specialists to participate. We have a lot of embedded bundles, within our ACO for our specialists, and we're able to design those and have them gain share in those things within the ACO model, within that shared savings arrangement. We've been able to engage specialists quite well in that model. Next slide. For small ACOs, they don't necessarily have that opportunity. They have limited risk pools and a lot of statistical variability. And they probably need to stay focused on high impact interventions, leverage partnerships, conveners, et cetera, to help them achieve that level of integration they need and the financial risk they need. Next slide. So this is just a summary of modernizing the incentives and physician alignment. I think we have to move in a direction where we have to move beyond just the Medicare risk arrangements and get to a point where our practices and systems are more fully involved in alternative payment models to really justify the expense and the care transformations to be able to do well. Next slide. I'll stop there. Thank you.
Thank you so much, Angelo. Next, we are excited to welcome Mr. Dan Liljenquist, Chief Strategy Officer at Intermountain Health. Welcome, Dan.
Thank you. Good to be here, and appreciate the comments from David, Clif, and Angelo, and agree with the sentiments they've expressed. I'm going to maybe click through just a couple of slides to get to the meat of what I would like to do. Here's a little bit about me. I don't want to dwell here, but I do want to talk, if you'll go to the next slide, a little bit about Intermountain's position. We are a large integrated delivery system. We have 30 plus hospitals, about 400 clinics, where we operate in 6 states and have about 48 or 68,000 caregivers that work with us every day. Our mission is to help people live the healthiest lives possible. This is a pretty unique mission in healthcare. It's one of the reasons why I love being here at Intermountain. I've been here coming up on 13 years, and in this role as Chief Strategy Officer for the last 6. Our mission used to be excellence in the provision of healthcare services, and about a decade ago, we changed it to this mission statement, believing that we can do better than just to wait for people to be chronically sick and try to patch them up at the end of their lives. If we reoriented our delivery system towards helping people live healthier lives, we could create an economic model that makes sense. Our vision is to be a model health system. This, when Intermountain was formed in 1975 by the Church of Jesus Christ of Latter-day Saints, donating the then 15 hospitals to the community, they stepped out of governance entirely and left us this charge: be a model system. If you go to the next slide, please. Here's our strategy. This is built right off of that mission statement of helping people live the healthiest lives possible, and our vision to be a model health system. Our strategy at Intermountain, what we believe the best expression of that mission is when we take full clinical and financial accountability for the health of more people, partner to keep those people well, and coordinate and provide the best possible care. That first part of that, taking full clinical and financial accountability, we want to, as Angelo spoke about, we want to align incentives in such a way that every time we keep somebody well and on their medications and out of a facility, if we've been prepaid, every dollar of cost reduction is a dollar of value creation. It is way better for the patient, it's better for us, and it creates an economic model that we can be proud of as we seek to do our work. We are focused on 2 major system initiatives to advance our strategy. The first is simplifying what we do for our caregivers, patients, and members. About 62, I think it was roughly 62% of people polled believe that healthcare was deliberately designed to be confusing. And when you see all of the different avenues of care, all the different options, we hand people essentially an insurance card, and when everything's on the line, wish them the very best to go figure out what they need. And that's where the lack of coordination of care, lack of awareness about how the systems work has really hurt our ability to meet people where they are and help them find what they need. And that complexity exists for our caregivers. So everybody who works at Intermountain is a caregiver, whether you're involved in direct patient care or you support those who do that work. But the level of complexity that we're dealing with inside of our organization is massive, and it's just as confusing, if not more confusing, for the people we aspire to serve, our patients and our members. So we are working very, very systematically to identify and remove friction in our system, to be much more situationally aware of where patients are, what they need, what's the next right action they need us to take on their behalf, so they need engagement around. And so we're orienting really all of our clinical systems and our analytics around that goal, to be aware, situationally aware, much more situationally aware than we've ever been about what's happening to patients. And that requires real-time awareness. It doesn't do you any good if you're waiting for a claims payment or claims reconciliation 2 weeks later to know what's the next right move to make for a patient today. We're also working on expanding proactive care, and Angelo spoke about this a little bit, speaking specifically around the need to expand these models. We all live in, with a foot and two canoes of Intermountain's roughly $18 billion to spend of revenue, about $5 billion is fully capitated. So we are very squarely in both boats. We believe that doing the right thing doesn't necessarily require you to do materially different things, but we do know this, that if we collapsed Intermountain's payment levels to the Medicare payment levels in the states we're in, we would go from being one of the healthiest health systems in the country to losing over $1 billion, if not closer to $2 billion a year. And the gap between commercial payment and where our Medicare benchmarks are in our area just make it incredibly important to make sure that we have models that work for our commercial business. And in the commercial world, 2/3 of that commercial business is in ASO models, self-insured models, large employer models. And so we are really working, how do we create proactive care models that work for commercial populations? And that's meaningful to us. I'm the son of an endocrinologist. I grew up around diabetes. My brother is an endocrinologist as well. It is, if we are only waiting until somebody turns 65 to engage on metabolic disease, we miss the real opportunity to change their lives. We should be engaging effectively in people in their 30s, 40s, 50s, when we can actually avert the complications of type 2 diabetes. We are very concerned that the focus on payment models only for Medicare dramatically risk a whole generation of people that if we engage more effectively, we could avert some of the crises. Add on to that, we're very concerned over the next 5 years, a full quarter of Intermountain's doctors and nurses are retiring. They're in the baby boom cohort. If we hired every doctor and every nurse out of every single program in all the states we operate in and retained all of them, we will be thousands of providers short, given the massive increase in demand and the retraction in supply. So unless we change how we deliver care, we will be leaving people behind. And unfortunately, we think it'll be leaving those patients in their 30s, 40s, and 50s who could really use proactive interventions to avoid, for example, developing metabolic disease, that our system will be so focused on caring for the baby boom cohort whose average age is now 71. They weren't expensive at 65. They're going to be very expensive at 75 and 80. And we're trying to figure out how to balance out the needs of our broader community with an unprecedented retraction in the supply of providers we have to do our work. So as you look at the bottom here, and I'll finish with maybe just a couple of comments. Our focused investments at Intermountain, we are adopting cutting edge technology. We are leaning in to AI. We are leaning into ambient listening. We are leaning into those tools that help our providers be as efficient as they can be. We are working on streamlining the consumer experience process, so we know situationally how to lower the friction points for people to access the care we do provide. And then we're reimagining our work. We are investigating every opportunity we can explore to decant volume out of doctors' offices to other settings. For example, we're working on a centralized medication titration, refill, and pre-authorization center so that we don't have to have our doctors taking up time for routine, prescription refills. Trying to find that extra 3 or 4 slots a day that we can open up in a physician's schedule to handle more patients. We're working on growing our at-risk payments, believing that if we do this, we can better align our system around what meeting patients where they are when their conditions are less acute, and helping them along their way in a low-cost model, but in a model that helps us move upstream, but also sustain our economics. And then we are on the bottom here, the bottom right here, creating expanding proactive care models. We're really working with our clinicians, with our clinical programs on road mapping. What is the right standard of care for somebody in their 30s, 40s, 50s? How often do we need to see them? How do we make sure that we are staying in touch with those communities at the same time trying to absorb the largest cohort coming into Medicare in the history of the program? So maybe you finish with next slide. How do you do all this? We are working to build trust with our providers, always communicating. One of the things we're working on is really getting to the point where we have daily visibility into how we're performing on our risk-based arrangements, and not only just at the program level for Medicare ACO, but also inside our hospitals, to be situationally aware of the patients we have in our hospitals that are on at-risk arrangements, so that our hospital administrators can better be aligned with the work we're trying to do to keep people well and out of the hospitals. If you go to the next slide, and then I'll wrap up. How do you do this? I mean, we are really going through a lot of change management with our 5,000 plus employed providers here at Intermountain. And it's maybe the most important thing we've learned is that we've got to listen, we need to act, we need to report back, we need to make sure that we are encouraging this feedback loop. Because what we found at Intermountain is our clinicians are bought into the vision, what we're trying to do. And that's encouraging. I think the models that we built across this country are going to be enormously stressed over the next 10 years. And the only way that we've found to be effective in reducing physician burnout is just being highly engaged with what they're experiencing in their daily lives. And this process, this simple process, has helped us increase our engagement and keep our clinicians here instead of choosing to opt into concierge models and just throw their hands up on the whole system. So with that, I'll just turn the time back over to you, Mr. Chair, and again, appreciate the opportunity to be here.
Thank you, Dan. Now we will open up the discussion to our committee members. So at this time, PTAC members, please flip your name tag up or raise your hand in Zoom, Josh, and if you have questions for our guests. Yes, Krishna.
This is probably more for David, I think. Just curious on best practices you have around how payments can be made to conveners, particularly for specialty-based models.
Yeah, it's a great question. I think in general, there are really, two issues with sort of the payment flow between conveners and their partner practices. One is that it takes a long time to change the health of a population. A lot of the interventions take years to actually generate the savings that result in the shared savings payment or the outcomes-based incentive payment. The second is that the fact that we have to wait, an entire performance year and then, 6, 9, 10 months for a reconciliation once we actually generate the savings. It's challenging for the convener to sort of keep the providers engaged and interested if they're not really seeing what, the work they're putting in bear fruit in terms of the value-based payment contract. And so a lot of what we're trying to figure out is how do we have a different payment flow that's occurring during the year that we're taking risk and passing that along to the provider partners. A lot of these conveners are backed by financial institutions like Rubicon Founders, for example. And the reason is because it requires so much of that upfront investment to sort of sustain that period of time to get payments flowing back to our partners, which is the ultimate goal, to reallocate those resources. So best practices, if there's ways for payers to sort of be understanding about the need to front payments as really cash flow. Payers are at this point wanting all dollars that they're paying out to be at risk for these types of arrangements, but some way to front the flow of funds so that we can keep our providers engaged. And then also having a reasonable ramp to two-sided risk, even with conveners, understanding the time it takes for shared savings to actually materialize. Again, given the sort of uncertainty about benchmarks and how challenging it is to baseline these types of populations.
Helpful, thank you.
Larry?
Thank you. So nice to see some friendly faces here. I'm going to start with just a follow-up for David. David, you know very well that Sonar it's a convener, and you worked with us that ultimately gave us a contract with Blue Cross North Carolina, so I appreciate all that. But those prospective payments are really necessary.
Yeah.
And the convener many times has to take risk on that, upfront payment in order to be able to carry this to a point where you can have a reconciliation down the line. The provider certainly can't. But my question, and this can go to all four of you, has to do with the ASO model. It was brought up multiple times. How do we have a convener in an ASO model where the health plan really doesn't want to go and renegotiate every single contract with each of its self-funded employer clients? This is a major impediment. The health plans will do it if they have full risk on that patient population. But in the ASO model, you have to do other models, like develop a friendly PC model where you're billing a CPT code. Have any of you come up with solutions for a convener in an ASO model?
I can give a quick response, but then happy to turn it over. We worked with some conveners in the kidney space in North Carolina, and we're able to get our ASO customers in that model because there was a broader payer infrastructure for value-based payments that these additional convener-based models kind of rolled up into. The challenge is really getting the employer groups to understand that if they're paying more dollars in their value line item, that means because it's more than that was saved to get that payment, and that's a sales issue, an education issue. But if there's a way to kind of tuck that in under a broader value program on the payer side, that's sort of how I've done it before, but interested in others' opinions as well.
Maybe I would just add, look, what we're finding here at Intermountain is our large employers are coming to us and they're saying, hey, I've got an insurance card that says I have your network and I can't get in to see anybody. And, we have tens of millions of phone calls we take every year, and it's basically the elderly population calling every 5 minutes. We have massive displacement of people who've been with their doctors for years and years, and their doctor retired right when they have needs. doing nothing, if we're not deliberate about this, we could be absolutely overwhelmed by the Medicare population alone. The needs are so big and the retraction is so significant that you're already seeing a substantial rationing of care, and that rationing of care is coming for people with commercial insurance who can't see a doctor and can't see a primary care doctor. We'll do surgeries on them because, you know, they pay well and you could get in for those, but we're talking basic routine care. So what we're working on at Intermountain is trying to figure out, okay, as we go and work with these large employers, we're exploring sub-capitation models for primary care alone with a corresponding guarantee for same-day access. And give us a sub-cap for primary care. You're paying a lot of this. You're just paying it through emergency departments or deferred care or deferred costs. And then with the goal to match that up with newer and less cost intensive modes of care for those people. Like, for example, we're exploring moving to a once every 3-year primary care visit, but same day access if you have an emergent, if you have a fever or some sort of thing that might require you to see, an urgent care, and even go back and say, we're regardless of this location of where we treat you, if it's this certain condition, we'll cover that in the subcap. So we're doing a lot of that work right now. And then frankly, our large employers who have folks in our states are saying, hey, that's something I'll pay for. And it's essentially paying for some access so they can get their people in to see folks. So we're trying to balance that out, but I don't know if that made sense to you, Larry, but that's some of the stuff we're exploring.
Yeah, I'll just add one thing that, we have looked at that over the years and toyed with the idea, is there a way to create a value network that would make it easier for the payers to, on behalf of their ASO contracts, to contract for certain kinds of services, capitation or otherwise. It's just a really costly undertaking to do something like that. And we were just never able to do it. But it is a serious problem. So, but no easy solution, I'm afraid.
And Larry, our experience has been more like Dan's, is that we've not really figured out a broad umbrella ASO type approach, but we've approached individual employers and offered them a spectrum of services that go all the way from minimal services, same day access, sub-capitations up to total risk with risk corridors. But we've had to do that large employer by large employer. We've not really had another mechanism for doing that through a payer.
I do have a follow-up question for Clif on benchmarking. One of the things that I see in my day job is that when we have private practices that are being compared against hospital-based provider groups, and we have a risk adjustment that's made between the two, the private practice always loses out on the risk adjustment to the hospital-based systems, and there's always a negative adjustment back because of the coding. The systems do a much better job at risk-based coding than the independent practices do. Do you have any solutions in that regard?
Not easy ones, but the coding problems and all the inequities in it underlie so much here of I think the problems in both benchmarking and reconciliations, and as I mentioned earlier, the disproportionate difference between MA and accountable care models. One of the benefits, I think, of the conveners, and they are now playing a much bigger role. I mean, when NACOS was started, when ACO program started, there literally were less than 5% of the ACOs in that first few cohorts that were part of a multi-system. Now there's over 50% of the ACOs are part of the either conveners or the multi-hospital systems, and the conveners do bring new technology, coding technology. I'm not necessarily endorsing that, but frankly, they do put the individual private physician practices on a more even keel, I think, with the capabilities of the hospital systems for coding. It's a whack-a-mole game. I mean, and somehow, I am hoping we can address the fundamental problem soon. It's driving, of course, the trust funds to a faster liquidation, and it is just not a fair system to the providers or, frankly, to the taxpayer. So but there is no simple solution, I'm afraid.
There's no financial incentive for a doctor to improve his or her coding.
Correct.
They're going to get paid the same no matter how they code, unless they're in a risk-based contract. Thank you.
Correct. That is correct.
Lee, and then Jay.
Thank you. This question is first for Angelo, but then I would certainly invite everybody's thoughts on it. And I want to ask your insight and wisdom to a piece of the ecology here that I've long been concerned about and asked questions about, and that's, to borrow Dr. Lynn's phrase, that's the last mile in value-based payment. So we do see increasingly in Medicare Advantage plans and some commercial contracts, they're paid as a capitation from a payer or some value-based arrangement from the payer to their contracted network, yet the contracted networks, the employers of physicians, by and large, still hugely pay their physicians fee for service. And I'm not saying that's absolutely required to see behavior change, but it certainly facilitates behavior change if you're paid to care for a population and not to produce RVUs. I've thought a lot of this is tied up into the fair market valuation rules and the fact that systems, counsel and compliance staff are very conservative, and it's just not changing to understand that you can pay on different bases. You mentioned the 2020 OIG final rule and reinterpretation. I just don't think that's really percolated through systems yet. So love your comments on what types of physician compensation arrangements you found most effective to change the mindset to caring for a population while still balancing needs for, access and, productive career physicians, that sort of thing.
Yeah, so thank you for that question. And yes, as you know, I agree with you 100% with that. And I think it's multifactorial. So again, as networks initially enter APMs, and they may be on a value payment only kind of model, your hands are really tied in terms of what you can do for practices, because their base salary has to be linked to fair market value. But as you move to more global risk arrangements and you get more and more global risk, then you do get leeway to do other types of support. And, the shared savings is not always predictable. It's not always something that you can rely on to incentivize, and there's always delays, as mentioned before, as to when you're going to get that shared savings. And so, once you reach a certain level of risk, then you do have, through the 2020 OIG rules, an ability to pay physicians for things other than their shared savings. And I'm not an attorney, but I know that this is the case. And so you can pay for such things as care coordination efforts. You can embed staff in those practices. You can pay for process improvement projects, things that you need to have done for the network. So there's an array of those kinds of things. And you can also supply in-kind services for them, like ambient listening, like a majority, if sometimes not all, of their EMR, as long as they're fully integrated, which goes back to some of those coding questions. If you've got an ambient listening device that actually embeds the note in an EMR, which there's a handful that will do that, then the EMR can capture those codes and more assure that you're getting accurate coding on those things. So there's a lot of leeway in there. I think you have to really judge, how much risk are you taking? Does that get you past the thresholds for the OIG regulations, and certainly have legal input into that? But that actually drives the clinical integration and the bigger systems that take advantage of that, because it's not just a fee for service, and then maybe you'll get some shared savings down the road. They're being paid to produce quality and clinical integration. So does that answer your
Maybe
question?
I would just add, Angelo, well said. There's more flexibility in these models than you would have in other ways. And again, the value goes to the patient. If you're improving that care, there's more leeway. I would say another big concern that we've had is that there's the unpredictable nature, and I think, Clif, you got to this, the unpredictable nature of what the economics are going to look like are a challenge. And you can be a large, sophisticated, integrated delivery system like ours and still be stuck on the wrong side of a contract, especially on MA when a plan gooses up your benefits and you're in a full risk arrangement. They can shift a lot of risk to you, and they do. And so over the years, we've had significant conversations with our payer partners and had to move away from some of them because the temptation to shoot for short-term quarterly earnings at the expense of the broader network is real. And I think we're seeing that with version 28, a retrenchment of all of the larger MA players, and they are doing what they can to keep their quarterly earnings, but without the risk adjustment, without the HCC uplift they've had. They're denying claims, and they're also shifting risk by adding benefits and then using the contracts against their providers. And what that's done, it's dramatically reduced the willingness of individual providers who have low capitalization, as David talked about, and who are terrified of bearing downside risk. It literally could wipe them out. And we've had our challenges as a large, sophisticated system ourselves. So there's just, if I were a provider and thinking about betting my practice, I would have a hard time betting on value-based care if I were like my brother. He's not doing it. He'll take upside-only contracts. But if the rules change and some contracting mechanism he doesn't understand moves, it could wipe out his practice. And so I do think, the more transparency there is about what particularly the rules will be, the more you can have people invest. And I served in the Utah State Senate, and I ran Utah's Medicaid ACO legislation, and we had tried managed care in the 90s. And essentially what happened, the reason why it fell apart in Utah, as we learned, was that every time you organized to keep somebody well, Milliman or some actuary would come back and say, well, the people you were caring for weren't that sick. And so you would have the savings taken off the table. And what it was is it was a one-way deal where the state benefited and the practices didn't. And so, we've tried to, the legislation I ran in 2011 tried to address that, but it really comes down to creating clear rules and being comfortable with what the shared saving is with the government program with the providers. And I could go on a little bit about what we did in Utah around that, but I do think this is an unpredictable environment for most of our providers. And unless it becomes more predictable, it's going to be left to large systems like Verizon, like Intermountain, and others who are willing to take these steps. But it's going to be more difficult for individual providers to even participate or know how to do it. So just my view, but I'm happy to defer to anybody else.
To
thank everybody for participating this afternoon. We're going to shift gears a little bit and ask each of you how your organization is approaching using AI in terms of your workflows, your processes, whether it's clinical integration, whether it's ambient listening, AI scribes, whether it's predictive modeling. How are you approaching it? Are you early adopters? Are you letting your existing software vendors incorporate into their own products? I'm just curious how each of your organizations are approaching it.
Jay, I'm happy to hit it fast from Intermountain side. We have offered to all of our doctors DAX Copilot ambient listening, and in all settings. We're rolling that out some of our doctors are really, really good at using macros, haven't found a big difference in how they do coding. But for some of our doctors, it's saving them between 90 minutes and 2 hours of pajama time every day. We've turned on, AI tools around drafting response notes to patient inquiries, and that's saving about half that time. We have about close to 70 different AI projects underway at Intermountain. Most of those are back office oriented. For example, we've taken about 30 minutes off of the time it takes us to do a claims denial letter appeal. But we're working systematically to smooth that out. One of the things we're maybe most excited about is using ambient listening for nursing. And we're working very closely with Microsoft on a nursing pilot. And we're taking our coding time per patient, per shift, per nurse down by about half. And the goal there is to increase our bedside time from about 36% to 41% for our nurses, which will help them maybe take one more patient a shift, or maybe even two, depending on how efficient we can be. And that is trying to be as proactive as we can with the dramatic nursing shortage we're facing. So what we haven't done, and I don't think anybody's figured out, is to really ground these AI tools in truly physician co-pilot type work, where a physician is getting real-time advice from these tools as they're scouring the record. We hope to get there, but that's going to require broader collaboration with other health systems around things like Graphite Health and some of the things we're working on. But we need leaps forward in productivity. And these tools are the best option we've seen. Comes with risk, but the risk of doing nothing is even higher in our opinion. So with that, I'll defer to others.
So Jay, I can tell you from our experience, we've implemented ambient listening in most of our employed practices already, and have seen the same kind of response that Dan quoted. Just they've loved it. It's decreased their pajama time. It's creating better notes from a documentation standpoint. Where we're struggling with now is getting that ambient listening into our independent docs practices, because as you can imagine, there's a wide variety of EMRs there, and we're trying to figure out a way to integrate that directly into the EMRs. So we're working with them on that. We are beginning to implement some care everywhere kind of things, so that patients from their phone can actually just describe their symptoms and get directed from an AI standpoint to their best site of care, whether that's an emergency room, a virtual visit, or office visit, or whatever, and it can, from an AI standpoint, determine that. And we've got some other care guide things for the primary care docs to use that can help direct them in terms of just guidelines and those kinds of things. So we think that's going to be a big issues for the future, and we're really betting a lot on AI.
I'll just quickly add at UNC, for clinical purposes, we have ambient scribe pilots rolling out that are being dispersed across the population, but that's about it.
Lauren?
You started to address my question, but I'll just add the question and give you an opportunity to add another layer. Each of you have talked about the importance of proactive prevention of costs from even occurring, or really prevention of risk in the population. And having worked in hospice and palliative care before, working in complex care and care management, we would call that anticipatory symptom management, anticipatory disease management. It's a completely different competency than what you function on in a fee-for-service environment when the payment model is structured differently. So I'd love to hear from each of you what clinician roles, technology, and practices have you found essential in success in delivering proactive care, or what are you learning about that you think will be essential to take forward?
I can give that one a shot. So I think the biggest transition, I think, is going to have to happen in terms of what you're talking about in a specialty practice that's not integrated and doesn't have primary care doctors advanced care planning, palliative care services kind of integrated or embedded into practice. And so first, from a clinician role standpoint, it's providers who are experienced in that type of care that you mentioned, whether you want to call it, the goals of care, advanced care planning, anticipatory symptom or disease management. Just having the thought process of and the training to have those conversations of what patients are expecting and hoping for down the line. Definitely not something I ever learned in residency as a urologist, and it's just incredibly important. And having individuals whose clinical focus is really on having those conversations and being able to communicate that well with patients and sort of elicit the patient preferences, which is a skill in and of itself. In terms of technologies, I think one of the things AI may be able to help with is patient stratification and cohorting of your high risk patients that us as clinicians aren't able to predict that very well at all, just by looking at the patient in front of us in clinic. And so being able to bring together both clinical data, outside records, social determinants, information to determine who are the patients that we need to have these conversations with, so that we can dedicate those resources I just mentioned previously to the right population of patients. And then, in terms of practices, in my mind, at least, having the financial incentive be flipped so that there's a reason to do this, and there's a business model for hiring these people, for investing in these technologies, and then taking time away from doing high margin procedural things in place, doing these types of conversations that are really aligned with patient goals of care. I think those are the three things that we need to do. Speaking specifically from where we are on the polar opposite side in community specialty practice.
So, Lauren, from my perspective, as you asked that question, I think it's a tough question to answer. And certainly to really do it well, we need sophisticated data analytics and AI. But as I think about that question, I think about two buckets. So one is on an individual patient level, what are our predictive capabilities to predict what they're going to be at risk for, and more broadly, related to the work you do, is predicting that in our communities. Where are our high risk patients living, and can we predict based on those demographics who's going to be at risk for what, and providing a broader population approach to those individuals while trying to focus individually on individual patients and their specific risk. Again, working across primary care and specialty care.
Yeah, maybe I would add, Laura, healthcare drives itself down the road by looking in the rearview mirror. And that's the biggest challenge with dealing with population risk is there's always a regression to the mean. Your sickest patients the previous year regress to the mean almost always. Either they die or they get better. And so we've been trying to figure out how to focus on rising risk. And if you're looking retrospectively in rising risk, you're going to miss a lot of it. And so what we've been, to Angelo's comment around AI, we've got 138 clinical systems that feed data into Intermountain. They feed them into 2,500 plus data tables that because there's no standard of what that data represents, we have an army of people that are wrestling with those data tables manually to try to get what we call a gold level data. And it's not gold level, it's still really difficult to understand what's happening. Some of the advancements that we're doing through collaborations with Kaiser and others with a company called Graphite Health, which is a nonprofit organization focused on creating what we call a semantic and syntactic data standard. Intermountain donated all of its clinical element models for free into this organization. We are working with Graphite to actually create a translation engine inside of our firewall in Azure that goes from 2,500 data tables to 3 and does that on a real-time basis. So we're able to feed our clinical systems into that data model quickly, which means that instead of having to wait for lab values to show up or for a blood pressure monitor to show up, we can do that within minutes and then run algorithms on that data. But that is a big hurdle for all of us. We've not come up with a standard as an industry to go back and have all of these clinical systems retrofit to a data standard. But as we upload our data now into the cloud, the technology is there to translate that data as it comes in into a cleaner data set. And we're working on that. We just finished, we're the first group to go live with this. Emory's going to go next, and we have a handful of partners who will move forward. But that is the most promising thing for us, because if we're able to do that, we should be able to identify rising risk in a real-time basis and using AI tools to do that. And that is the goal, to move away again from looking in the rearview mirror to being able to react more aggressively. In fact, that engine that we are working to build is, we are calling it the next right action engine. And it's like, what's the next right thing to do? Be driven by clean data. And that gives us some hope that we might be able to get on the front end of some of this. But it's enormously complex. And our data points right now are so limited as to what's actually happening with our patient base that largely even the best systems are largely flying blind here.
And a question for you to follow up on that. As you're coming up with a next best action, is this a clinical action? Is this addressing care management, care coordination? And do you have insight into what is driving that potential risk of negative outcomes? And then I have a next question for the entire group.
Yeah, great question. I mean, a lot of that next right action is, if you're in an episode of care, it's understanding what's the next right thing to do in that episode of care. It's, okay, we're going to get you, we found adenocarcinoma in your colon. The next step is a CT contrast, and we're going to make that really easy to do. We're actually pretty good at that stuff now, because we have teams of people who are looking at that. Where we struggle is, hey, you're 30 years old. What should you be doing? And the models there have not been developed. Like, what's the right thing to do for a 30-year-old? So, largely we've been focused on, Intermountain's known for its quality, but a lot of that quality is episodic focus. It's not really longitudinally focused. And we're working with our clinical programs to build that longitudinal view, but we needed to do both. We need to know where somebody is in a particular pathway, so that they can get the next right step done, and have a broader mechanism wrapping around them to say, okay, when we have a touch point with them, let's make sure they're getting their vaccine. Let's make sure that, hey, the colonoscopy guideline moved from 50 to 45. Let's get you scheduled. It's making that stuff easy and intuitive, but you've got to get really, really good episodically as well. And so we're trying to figure out how to create the awareness across both of those kind of in-depth episodes and the longitudinal pathway for our patients. So not easy stuff, but we do think the technology and the awareness, we can build the awareness. We can be a lot better at it than we are today.
I'll share that. I was at Vive maybe about 2-3 weeks ago, and it was, the theme was AI to solve for some problem or another, whether it is figuring out the next best action, how to solve for the workforce, ambient listening, how to call patients and make appointments, et cetera. And so as we think about these different solutions for workforce shortages and et cetera, appropriate documentation, risk management and whatnot. But I want to switch gears a little bit to the question around benchmarks, right? To have the resources that are necessary to be able to deliver this care and invest in these models. So to that end, what are best practices for improving the predictability of ACO benchmarks and to effectively address the ratchet effect? And whoever wants to go first. Presume it's going to be Clif, though.
I'll give it a try. So the predictability there's various components to the benchmark, and I think we have relatively achieved agreement that the baseline includes it's 3 years basically of historical. Sometimes there's debates about how much weight would year 1, 2, 3, or even 4 and 5 have in that benchmark. Then the problem comes with how do you adjust for all the different factors that come to play in the future. And I don't think we are at a point where everybody is certainly comfortable. I'll address the one element that is kind of the elephant in the room right now for the ACOs, which under the MSSP program, there was an effort to bring predictability to future benchmarks. And they incorporated a called the ASPE. And that is a prediction about what the total costs are going to be risk adjusted over the course of the 5-year contract. CMS had projected that at 3.9%. So ACOs signing up in 2024, that was the component of the benchmark. It turns out that 2024 spending is almost between 9 and 10%. So how does CMS adjust for that inaccurate estimate, and why was it even created? And if we don't fix that problem, the result will be that ACOs will lose almost $100 million in potential earnings through the shared savings. And so there's everybody wants a predictable, stable, future-oriented benchmark, but we still don't have the solutions to it that I think everyone is comfortable with. And we're working on those technology, whether AI actually will bring a better tool for predictability of trends in spending, whether they're national, local, or even for an ACO. I'm not sure. It certainly should, but I've not seen any reports of experiments or tests of that yet. But anyway, there is no simple solution.
Jim, if you have a question or comment on that.
No, I want to switch. Can I ask a different question? Yeah.
Of course.
Yeah, thank you for sharing. And I was particularly intrigued by, Dan, some of your comments about where you're moving with your data and some analysis. So I'm kind of going to direct this question toward you, and then maybe others would respond. The next right action, oftentimes, in my experience as a provider and then leading an ACO, we're directed toward community level issues that patients were struggling with in order to achieve their maybe control of their rising risk. I'm going to pick on that one. And I'm curious about what you might think, what the group might think about what AI might actually miss on or undervalue factors because of a bias in the data toward people who have utilized the system more disproportionately more than others, and hence undervalue or underpredict, if you will, the next best action to take, which is really more of a social determinant, community level, rather that affects the individual's health-related social needs, that would ultimately produce a lowering of their rising risk. And I'm just curious about how you're thinking about that as you kind of lean toward AI as a solution, and how are you thinking about mitigating the AI bias risk?
Yeah, really great question. And boy, we have not figured this out. We do have some ideas we're working on. One is, think about it this way. There are significant asymmetries of information. And you're going to miss what's happening in relatively healthy people's lives until they understand there's an issue. I'll give you an example. My daughter was diagnosed with type 1 diabetes 2 years ago. She was 13. Our demand for healthcare services were fairly elastic until they were inelastic. And then all of a sudden, she went from being a relatively healthy 13-year-old to having tremendous needs and and that expectation changed dramatically. Now, she had diabetes for about 6 months before her pancreas completely failed, and so we had that need. You miss that all the time. You also miss that with somebody who's got hypertension, but they don't realize they have hypertension and they're in the 30s. So you're going to have asymmetries of information. I think the difficulty is, how do you engage with somebody who's relatively healthy and has the beginnings of metabolic disease, and yet it takes them 6 months to see a doctor and they have to wait for hours to try to get an appointment? And how do you take that? How do you make the ability to interface with the system far easier and far cheaper to do? Because again, if somebody with type 1 diabetes is going to wait to see a doctor no matter what, they need insulin or they die. Somebody who's got the beginning stages of obesity, and where we could really make a difference, doesn't. So we've been trying to figure out, and this is the analogy we've been using. I have a neighbor who's blind, who's a runner. And you'd ask, how does a blind person run? Well, she runs with a friend who is loosely tethered to her, and they run. And every morning when they come up to a stop sign, it's the tether tugging just a little bit to nudge that person to slow down and make a different choice. We are trying to figure out, Jim, how to build that tether, that ongoing relationship between a health system and a patient, to give them nudges. And it may be as simple as, hey, you're coming up on your 30th birthday. Here's what we recommend you do. It's so that we can get some data points, so that we can identify hypertension early, so we can get somebody, if they ever become affordable, on a GLP-1 as a prophylactic measure against, the development of metabolic disease. It's figuring out those interactions when the demand is low that will create additional data sets to how to deal with the population. Now, to the overall bias that's inherent in the data, we are very, very concerned about that. We saw this play out in COVID, that the treatments just were dramatically different, and there were a whole bunch of other factors that came in. Our Pacific Islander population, for example, died at twice the rate our Caucasian population did here in Utah. And so I think what we're mostly focused on is being very hyper-vigilant about the tools that could drive that bias and systematize that bias. And they're subject to a higher level of scrutiny, even up to our board, in viewing our assessment of whether or not that we are challenging what the results come out of those tools. But again, we are dealing with imperfect data sets as they are. We're trying to figure out how to expand the data sets into a broader realm, so that we can more effectively engage with people when they're well or developing early stages of diseases, and then working to refine around particular populations our data, so that we can, again, that next right action hopefully one day is going to be driven off of the best knowledge we have about that particular individual, their genetics, their makeup, their social determinants of health, et cetera, so we can maybe meet them where they are. But to say that we figured this out would be a gross understatement. We're just at the very beginning of this.
All right, just one follow-up was just, is there any of you using any type of analysis for AI bias as you're selecting your AI tools? Is that part of the contract conversation? Are you aware of any AI bias checks and balances within the tools that you're looking at?
It is definitely part of our assessment, Jim. What is tricky about AI is getting replicable answers. And it's often the underlying structure of your data sets have more to do with getting replicable answers than maybe the tool itself. And so clinically, we are having a clinician engage with every point when a result comes out. We require clinicians to be involved, but it's really hard to tell how much bias is inherent in the system as it is today, and how much is being reinforced by AI. Something maybe Angelo, David, Clif, you guys have better perspectives, but this is an area of deep concern for us.
No, I don't have anything to add to that. I think that was well said. You probably have more experience with that than we do, but
Well, at this time, we have a break until 2:50 Eastern Time. Please join us then, as we have a great lineup for our second listening session, with experts giving their perspectives on supporting primary and specialty care transformation. Dan, Angelo, David, and Clif, thank you so much for joining us.
Thank you all. Good.
Thanks for your service.
Produced by the U.S. Department of Health and Human Services.